healthy. Being healthy is around. That's what I want. That's what I want to start saying. I'm healthy.
Yeah. Judy, did you know I'm pregnant? I know. This makes it on a recording. Yeah. Hi, Sarah and Maria and Carolyn.
I'll text you.
Yeah, yeah, of course.
All right.
Jump on in?
Yep, I think you can go.
Yeah. So this actually should look fairly familiar to Cami and Kyle because you've both received this training before. But when our clinicians are logging into RedCap, this is kind of what their homepage looks like. So they'll see all of the current users. If it's not somebody from their side, it's somebody from WSU. It'll show them how many records. We tell them to ignore this because it captures like all of the additional information. So it will double do if there's family or if we're providing reports. But then I don't think, Kyle, you were here for this. We are now able to calendar for everybody as well. And so they can see their upcoming events right from the homepage. And then we have everybody just navigate to this record status dashboard on that left-hand side. And that will show them everybody on their caseload. I'm showing Ryder today because they're not with us anymore. And they can add new records right from here. And so I thought I added everything for them 1 minute. They did not opt into really anything. So one of the optional measures is the prodromal questionnaire brief version, and that's got 21 questions. It's going to be very similar to the CAPE P15, if any of you are familiar with that. One of the unique things about this measure, though, that we like is that it could be done with family members as well. And so whoever's really making that consultation, they can provide the information about what they're seeing. Doesn't necessarily have to be with the individual. And so it'll say, you know, do familiar surroundings sometimes seem strange, confusing, threatening, or unreal to you? If you answer yes, it's going to be just like the CAPE, and it's going to ask how distressed that's making, how much of an impairment are you seeing around that question? And so you'll go all the way through. At the bottom, it's going to automatically score it for you. Anything higher than a 6 for the PQB, yes, no's, or for the distress would indicate that they potentially are experiencing at minimum clinical high risk for psychosis and potentially would be a good fit for moving through to the screening process. Any questions about the PQB?
I might have tuned out. So this is going to replace the CAPE? Is that what you were saying?
No, this is an optional measure that
okay.
people can do like during the consultation or the referral process with whoever is making that, like particularly during consultation where people are like, I'm not really sure if this is a good fit. This is a tool that they could be using for that. Any other questions? Let me open up the chat.
How often is this measured? I mean, if they do it the first time, are we re-administering it at a point in the future to kind of catch up, or is this just a kind of a set in stone document for records?
This one is only done prior to, like it's a unique one. We have our intake measures. This happens prior to that, trying to do it during the referral screening process. So you'll never do this one again.
Okay.
What is the time frame for implementing? If they choose to do it, it would be during that consultation portion. There wouldn't be a whole lot of benefit to going backwards for this measure.
I'm gonna throw in the chat the most updated measurement battery. The measurement battery will describe all of the measures that Bry's kind of go through, and it shows the frequency of those measures. And so a lot of measures are at intake only, the PQB, and it also shows what measures or assessments are optional right? So the PQB is an assessment that is optional. So sites can elect to have that included in their data platform and utilize that at the point of screening. Not all sites utilize the PQB. And we're currently in conversation about what screening tool can also be integrated into the measurement battery as an option for individuals with major depression with psychotic features and bipolar with psychotic features as well, right? And so the PQB is really for individuals that have a schizophrenia-related spectrum disorder. And so there's going to be a slight modification, like in the next couple of months, with the introduction of that sites can opt into as optional.
So then they'll move into like where we would capture all of the demographics for individuals. We just call it consult referral screening because that's effectively what they're doing. And Frontier is the agency that really requested that we add this consultation portion. They spent a lot of their time dedicated to talking to individuals who never even made it to a referral, really wanted that captured. So it will ask, when did that consultation happen? Who had requested it? What was the method? How long did it take? And did it result in a referral to the program? If yes, that referral pops right up. If no, then it's going to ask why not, and you check all which apply. And then it just continues to build upon. So it will ask a little bit more about race and ethnicity, about gender, if they qualify for screening. Then we'll ask things about whether or not they did the skid, where they're currently living, what their sexual orientation is, their specific date of birth, etc. And then they'll move on to determining whether or not the individual was eligible. Any questions about this one? Okay. Things are kind of laid out in a step 1, 2, 3, 4 so that they know the order in which they should be hitting things. So we're now in step 2. Every single person has to have a status regardless of whether or not they were eligible for the program. That's how we track how many individuals are being referred that are not eligible to receive services. We have a document here that people are able to print out at any point that describes what all of the statuses are. And we walk through this with them during the training. It builds every year, though. I think when I gave this training to Kyle and Cami, we had like 6 statuses, and we're now sitting at 14. So people will come through and say, like, I've got this really weird situation. Can we add a new status? And we'll do that. And then we also check how statuses change across time. And so maybe the person came in as pending, and then it changed to provisional admission. Once that provisional admission comes up, they have to say whether it was effective or non-effective psychosis. That's how we're keeping track of that now, but it's also what brings up whether they're going to do the general behavior inventory or whether they're going to do the CAPE P15. Any questions about the status form? And then they'll move into like step 4, which is really where they're going to do that intake. We mentioned there's a lot, particularly if they've opted into the full battery, but even just the core can be a little bit overwhelming. Individuals come in, they're meeting a lot of different people, they're being handed a lot of different papers. The expectation is not that they're doing all of this in one sitting, and it's definitely not that they're doing it all with one person. We want to really normalize that measures are a part of the process for receiving services. We don't want them to dread seeing an IRT because the IRT is the person who's doing all of the measures with them. And we want to make sure that it's spread across the 28 days that they have to do it, that they're not wasting potentially an entire session just doing measures. So if the PHQ-9 will ask how it was delivered. Client through survey means that the individual did it autonomously or outside of the session. Otherwise, we ask that the person who delivered the measure is the person who is selected. We'll ask whether or not they completed the measure. If yes, it pops up. If no, it's going to ask why not. We ask that since you do have 28 days for the monthly, 3 months for the quarterlies, etc., that you try at least twice to get this information. But we do recognize people go on holidays, people go to inpatient, etc., and you just write like we couldn't get it. So long as there's some reason, it doesn't necessarily count against that 70%. We provide them 2 numbers on their report. How many measures could be used for measurement-based care, and then how many measures had information in it. And that would include a reason for non-completion. And then they can also toggle back and forth between English and Spanish, which helps a lot in Yakima in particular. So this is the PHQ-9. We tell them to pay a lot of attention in particular to this last question. This was a lot more poignant before we added the Columbia Suicide Severity Rating Scale, but really just keeping track of whether or not an individual is indicating that they're feeling thoughts of hopelessness or that they might be better off dead or of hurting themselves in some way. When all of us run the monthly reports with the sites, if we see discontinuity between what the client is reporting here and on the Columbia versus what the clinician, because we'll ask those questions on a different measure, has the individual reported to you whether or not they're feeling suicidal or they have suicidal ideation or that they might want to hurt themselves and they say no, but the client said yes here, we'll call it out in the monthly reports and have conversations with them about that. Any questions about this particular measure? And then all of our clinical measures have,
I don't know if you see
yes.
the chat, but Sunny has some questions in the chat. I don't know if you want to just take them later after you do this, or because you asked if we had questions, and there are questions in the chat.
I apologize, Akansha. I did not see the chat.
Yeah, no, I figure when you're on screen share, you don't know what's going on. So, do you want me to ask the questions now or save them for?
I can actually read. Thank you for pulling that up. Sunny, we have calendars. And these are printable as well. And so the clinicians can go through, they can look at what they have for their day, for their week, for their month. And the nice thing is that they can also click directly into it and see, okay, all of these are gray, which means we've not done any of these. And so it will let them know on the calendar exactly how much they have to do.
Great, thank you. And a follow-up question: are all of the measures showed up in every team members, or it's this the system will just designate certain measures for the people who are responsible?
We provide guidelines on who we think should be completing the measures because, as we said before, we really don't want it to fall entirely upon the IRT. However, each of our sites does it a little bit differently. So we'll say that, for instance, with the PHQ-9, that really should be the IRT specialist. But as we go through, you'll see like the functional outcome measure that fits best with a C. We'll do the substance use measures that fits better with a C. We have the process of recovery. I personally think that fits really well with a peer. The peers that I've trained really want to be able to use these in their trainings. And so they think that's a really good measure for them as well, but it also fits for any team member. And so when we do the trainings, we'll describe that. We have those tables that give who we think should be doing it, but ultimately the teams are deciding how to break this down.
Thank you.
Yeah. But we do have graphs for the clinical measures. And so we really do recommend that as the clinicians are completing it, that they're going through and they're showing like, okay, let's look at how things are changing over time with you when you came into the program you had a score of 10. And that has been increasing overall across time. Have there been different life circumstances? Is there coping skills that are just not working? Can we work with you on those coping skills, etc.? It does look like ultimately now that this individual is in year 3, it's starting to reduce again, which is good. But we have this for all of our clinical measures. Any questions about graphs?
So is that just is there a certain place that people click on to, if we were to pull this up in a consultation call, for example, where would we guide them to pull that up? Is it just a graphs tab?
It sits, I moved out of it. Sits right here, right in the front, because we want them to be able to access it for each individual. And it's just step 2. We tell them all the time, like, you could be using these in your weekly meetings to really see how things are changing. You should be using it when you are working with the individual specifically as a way of kind of encouraging completing the measures, but also seeing how things are changing and looking at like different time points where that may have been changing for you. I think at one point, Cami, when we did the training, you had mentioned that you bring it up a lot when you worked at DHR, and it encouraged a lot of your individuals to continue asking to complete the measures if they actually get that visualization.
Yeah, and I don't know if Dooney shared with you, but when we did the fidelity review for BHR, we could see measurement-based care being used by them, and they were pulling up the measures, and that was neat to see it being implemented in the sessions.
Awesome. Kyle, did you have a comment?
Yeah, I was gonna champion what Cami was saying, and the use of those graphs is, it's like one of the individuals I worked with said it's like taking a test and never having your score. Like, you know your number, but it's like, hey, what is that accumulating to? And so when they see progress or recession in their graphs, that's where we can talk more about interventions that are helpful, and right, that sparks a conversation about why is there a dip here? Well, life occurrences may have happened. So really being able to remark on how the ebb and flow of normalization, as we teach that this is a normal flow for a lot of people, is to nobody's happy all the time, nobody's sad all the time, right? And so just being able to normalize that experience for the individual, the graphs really help visualize where that is and why it is. So just want to really advocate for the use of those graphs.
Yeah, thank you, Kyle. That's said better than what I think we say, but we try and impart that same information as we're doing our trainings. And then Akansha, I know that you directed that to Cami. At least all of the sites have access to the graphs. Whether or not they're using them, I'm not really sure. So the generalized anxiety disorder 7 item is our next monthly measure. It's going to be fairly similar to the setup of the PHQ-9. I think everybody in this chat has probably taken this measure at one point. And it will automatically score for you. And again, you can look at those graphs to see how that's changing over time. And that is another one that we recommend that the IRT. Lifetime drug use, monthly drug use, same measure. I can't remember if it was Cami or Catherine who brought it up, but it was definitely BHR that said, a lot of their individuals were really working towards abstinence. It worked really hard towards that. And it was becoming very distressing to have to continually say, yes, in my lifetime, I've used this substance. It disregarded a lot of the work that they had done. And so we made that adjustment. So it looks like there's 2 measures. There's only one. It's because we pivot after lifetime and say, in the last 30 days, have you used this substance? And then I think Victor brought up in our last group meeting that this can be a bit of a long measure for individuals who aren't using any substances. And it would be nice to just have a button that says no. Like I haven't. And so we made that accommodation as well. And you can just say no, and that measure is done now. But if you say yes, it's going to ask, have you used this? And if yes, how often have you used it in your life or in the last 30 days? We do this one monthly, and we recommend that it is the C specialist that does this one. Any questions on this measure?
Do trainers have access to the measures?
I don't know that I understand the word trainers. I'm sorry.
Oh, like all of us here.
I think Dooney just put it in the chat.
Oh,
So it's definitely in the packet.
okay.
Mm.
Can we have the access to the to recap? That's what I meant.
No.
Okay.
So then monthly drug use looks the same as that. The clinician rated psychosis symptom severity, we just call it the CRD-PSS. It'll ask whether or not they saw the individual in the last month. This one's a little bit tricky. It is technically a clinical scale and should be completed by the IRT, but we really recommend doing this one in the weekly team meetings and that it becomes a conversation with all of the people on the team. Because particularly at intake, I think people tend to want to see like the case manager, the C specialist, the peer more than the IRT therapist. They don't feel as comfortable talking to the IRT. Therapy doesn't necessarily seem as accessible as like, oh yeah, obviously, like I want to go back to school. And so some team members may be seeing things or have things disclosed to them that others have not. And so having that conversation really allows you to drill down into some of these symptoms. And then this is that verification and the second half of that Columbia scale, asking about suicidal behaviors and self-harm, where we look for that continuity between the two. And again, this is why it's really important to discuss as a team rather than having one person. We recently did a project on looking at suicidal disclosure in New Journeys. And a lot of the C specialists and peers were the ones that people were coming to rather than the IRTs because they just didn't feel as safe talking to the therapist about it as they did talking to their C specialists and their peers. And so oftentimes, and at Ryder in particular, Ryan had mentioned that there had been times where their C specialist had disclosed and did not know that they needed to tell the IRT that that was something that was happening. And so you need to have this conversation as a team, and this would help facilitate that. Any questions about this? And then the last monthly one is the service utilization. And so this is where it's going to ask in the last month, how many sessions were scheduled, how many sessions were attended. When we do our monthly reports with the sites, we do an aggregated for them. And so they'll be able to see in the last month how many total sessions they scheduled for each thing and how many total sessions were attended for each of these. And everybody who has access to REDCap should be able to pull that up at any given point if you ask for that information. This one is a little bit different to all of the other measures, though, because it's not on that rotating 28-day basis. This one looks at actual calendar months. So in the month of February, how many sessions were scheduled? And that's reduced a lot of the burden off of the sites because they're not having to like find these individual dates for each individual to figure that out. The P15 is our first quarterly measure. This one is done if they have a schizophrenia spectrum or if it is depression with psychotic features. And it's going to look very similar to that prodromal questionnaire that we talked about. So if they say anything other than never or skip, it's going to ask how distressed were they feeling? And that's really important on this particular measure because we tend to see a lot of underreporting of symptoms. But what we don't see is that when somebody does choose to report a symptom, they're not like faithfully saying how distressed it's making them. And so you may see that their clinical score is less than what's considered to be significant, but you can really like help them by focusing on where those distress points are. And this is another one for the IRT specialist. Any questions on the CAPE? Yeah, absolutely. Do you need anything specific in order to, like, were you just wanting to anecdotally share what I just shared with you, or do you need me to provide some information?
Information would be great, but I don't want you to have to do anything too much. But yeah, anything about what you've noticed with respect to suicidality coming directly from our data might be helpful. I don't know. Are we allowed to kind of disaggregate stuff in that way and kind of piecemeal present information, or should we all just kind of wait till it's all presented together?
I can give an aggregated overview of what we're kind of seeing. And then I can share some of the quotes that were given about it so that you can share that feedback if that's useful.
And I'm not the one managing the call, so I should actually check with Katie to see. I know there's already an agenda, so I don't know if there's space for that, but I just figured since we're going to be on that topic.
Yeah, I think that there would be opportunity to share some of that feedback, and I think that that aligns with what we're trying to do with better integrating measurement-based care in what we're doing. And we can also point towards that Columbia assessment tool being a part of the PHQ-9. So Mackenzie, I know that Mackenzie and Cameron, you've been managing that agenda. Is that something that sounds reasonable to add in? And yes, and letting Jeff know. I think yes, Cameron will have to answer that question, but
Yeah, just wondering how long we'd want to talk about that, but I'm sure we could chat about it and fit it in. And if not, just share the resource as well. Like we can share it afterwards, either way.
Yeah, and it could be something that maybe we pass on to Jeff to present, just as like what we've collected from the teams, and again, nothing to harp on, just like why it's relevant to the work that we do.
Yeah, definitely. I think it's good for teams to know.
I think it's a good idea to pass that information on to Jeff for sure.
I mean, I don't know, or we could just ask Jeff if one of us could present it. It might be like he doesn't know the context, but just like, if he just puts in a slide context of new journeys or something, and we send like, it might make more sense for maybe, Cammy, you or me to just like go over the data, but because we just know the context better and like inviting people to think about the implications of that for who completes those measures, just that we kind of have more control over how it's
Yeah, I don't know. I mean, I'm not going to be there for next week's Echo Clinic, and so I would defer to maybe you, Akancha, doing something like that, or we could invite Dooney or Bry to maybe talk on that for like 5 minutes at the end of Jeff's segment before we jump into like Q&A.
Yeah, something like that. I think if Bry or Dooney, you can make it, um, and then we can fold that into like the clinic. Is it a didactic echo so there's no case presentation?
Yeah.
Yes, we have more time to really think about what are the and this is exactly what we want to do, right? Integrate measurement-based care into more clinical practice, and I think it's a good modeling for them as well, how we all function as a team, right?
Yeah,
So,
I
like
like that.
if Uni or Bri were presenting it, and then Steve and me and Kyle and Sunny if you're there, and Lauren as the clinical team, implementation team, were like, okay, so what does this mean, right?
Yeah, I can go. Dooney will not be here next week.
Okay, cool. Thanks, Bri.
Cool.
Mhm.
So Cameron and Mackenzie, can you follow up with Jeff about those, just integrating that,
Yeah, we'll say
please?
5 minutes. That sounds good. Or do you want more
Yeah,
time? Yeah.
I think 5 to 10 minutes would be more than sufficient. Unless you disagree, Bry, since you're the one getting signed up.
No, that seems fine.
Just voluntold you, sorry.
You're all right.
Steve's
We're integrating.
So you'll notice I changed the status and this line grayed out, which is the CAPE. So now the person has bipolar and we can do the general behavior inventory instead. And so this one is 10 questions. Again, would probably be done by the IRT. And then we do provide those clinical cutoff scores as well. I'm going to move a little bit faster because we are running out of time. We have quite a few measures left. But that one is also quarterly. Functional outcomes is one that we recommend that the C specialist does. The C specialist could do this one in theory, even if the individual didn't show up, they should know whether or not the individual has a goal for school, whether or not they're attending school, whether or not they're employed. And the teams would be aware of whether or not they had interacted with emergency rooms, crisis, etc. This one is really important. I think Cammie's aware of this, having worked at HCA. We have to report to the healthcare authority every year how many individuals have had an interaction with inpatient and how many individuals have had an interaction with the law enforcement. And so our only way of getting this information is if this particular measure is completed. Any questions about functional outcomes? Medical measure, it again looks like two, it's just one. We have a brief history at the end, asking about whether or not the individual has hypertension, high blood pressure, etc. That disappears after intake. And then it's just everything from date primary care provider was last seen upwards. This one is kind of tricky for a lot of our sites to do. They don't always have access to being able to take somebody's blood pressure. And if they don't, that's okay. If they can get it from the provider, fantastic. But if they don't, we tell them that's okay to just not put in. And then we'll ask them if they're prescribed any medication, what the potential side effects are that they're experiencing, and if they're on that medication, dosage, days prescribed, and last day taken, or how many days taken. Same thing for long-acting injectable. This is a good one for a nurse or a case manager. We don't ask prescribers to complete measures. A lot of our teams have indicated that's too expensive. At Valley Cities, they used to have the prescriber give the C specialist all of the paper versions, and then I think, Kyle, you just entered them all in. But I think for the most part, it's the case managers who are doing this one. Process of recovery is my favorite measure that we have. Every other measure that we do ask, what's going wrong and is it getting better? This is the first one that goes, what's going right? It doesn't make the assumption that just because we are reducing your negative means that we're increasing your positive. And so it'll ask, does the individual feel better about themselves? Do they feel like they're a part of society? Can they identify positive things in their life? Peer specialists seem to really resonate with this measure. And so if the teams have peers, we say that this is a good fit for them. But it really cuts across any team member. Most of our sites were already doing some trauma measure, either the CATs or the life events checklist. And so the only adjustment that this one has had is that we're now doing it quarterly. It used to just be at intake. But now the assumption is that trauma can happen, or traumatic events can happen at any point. And if they endorse any, it'll follow it up with the PTSD checklist where they'll identify what's causing them the most distress and then in what ways. And that's a good one for the IRT. Sleep is a new one. This one was really well received. We are currently doing measurement-based care surveys with the individuals who have been served and are currently being served in the New Journeys network. 100% so far of individuals who have participated have said that sleep is something they really wish that their clinicians had been aware of. And so it's a good measure that we have now incorporated on a quarterly basis. Any questions so far? And then we'll follow up with demographics every 6 months. It's a really abbreviated version of what they did at intake. And that's the end of our core battery. So from here on, everything is optional that they can choose to do. Experiences of discrimination. I think this is one that Dooney really likes. It talks about experiences they've had in their lifetime and experiences that they've had every day. If they endorse anything, it's going to ask why they believe that event has occurred, and they can select all that applies. The measure itself is designed where you have to select one, but we've adapted that based on feedback from clinicians where individuals can select specifically anything. The Compass 10, most of our sites opt out of. They see a lot of value, particularly Heather at CMAR sees a lot of value in this measure, but it takes a really long time to do. It's more qualitative than anything else. And it's going to talk about depression, anxiety, suicidal behaviors, a lot of the symptoms around psychosis. It's going to be mostly conversational, and then you'll pick whether or the severity of that symptom. We don't often see this one being completed though, because this could take the entire session and you wouldn't get another measure done. ADHD self-report screening, I think it's just 6 questions. Victor at Comprehensive really likes this one. Said it's been really useful for helping him identify whether that needs to be an additional screening that they do. The McLean is for borderline personality disorder. It is 10 questions, anything a 7 or above is considered to be clinical significant. None of our measures are diagnostic, so everything is indicating that they need to potentially go and seek additional screenings. And then the perceived stress scale is the only optional measure that happens quarterly. And I think most of our sites opted into this one, and it's generally the case managers who are doing this one. But I think it's another one that could potentially fit well for peers. Stress is something that everybody is experiencing. It's very normal. And the peers have really liked this measure as well. We have file repositories where they can, except it's not on this one for whatever reason, where they can go and download the books at any time, or like there we go, the measurement battery if they want paper versions. And then this is what the monthly reports look like. So we did Victor's this week. It'll show them how many individuals have ever been referred and what the current statuses are for everybody. It shows what the service utilization looked like in an aggregated form for the last month. It shows their core battery completion rates and measurement-based care completion rates and whether that's improving over time. We provide them with an Excel. Where we look at each of the individuals on their caseload, what was due, whether or not it was due, how it was completed. So like CR means that the client refused to do it. And then we break it down so that they can see their trends of how measures are being completed over time. Is there anything that anybody wanted to see that maybe I sped through really quick or was not aware of? Sunny, did you have a question?
Yeah, Brian, this is really good. I was wondering, do the team members get any training for, getting familiar with using RedCap, or just is there any onboarding or training for using this platform?
Yeah, whenever team members come on board, they receive training. Sheldon did one this morning with the new director for Grant County. Anytime somebody comes on board, they get about an hour's worth of training. We typically ask if they want follow-up, and we encourage them to do a follow-up because sometimes you don't know what you don't know until you're in the system. And so we'll ask them the next week, hey, do you want to touch base again? We also do ad hoc training. So if directors identify team members who potentially aren't using it very well, we'll do it with them. If they're consistently falling below that 70%, we'll schedule a mandatory retraining with them. And then every year as we update RedCap, we give team training.
That's great.
Any other questions?
I appreciate the time and the overview today, and it sounds like we have some good ideas about doing some more integration of measurement-based care within our own consultations as well as with Echo. Any other thoughts from the rest of the trainers around integration of measurement-based care within our own training or consultation?
So with these suggested measures for, like, say, C, is that something that I should be pushing, I guess, more than often? Because the reason I don't necessarily is because I know there's a per team kind of, the way the certain teams structure, the way that they administer these, the way that, they're basically divided amongst clinicians on the team. So I guess I would just if I could get a more specifics for, should we be pushing the measures for, or just generally to do measures, I guess is really what I'm asking.
I wouldn't say that you would be pushing for individuals to do measures. I think that there's a way that you can ask, everybody on the team has access to the measures, whether they completed them or not, right? And so I think in what I envision is that you would be asking about how is employment rates going, right? How are the employment goals and addressing those employment goals or educational goals going? Have you been able to achieve those goals? If you're completing certain measures or assessments, such as the ones that we suggest that are assigned to the C specialist, then it's following up on those. Like, how's it going in this particular area? You can always go back and look at your data platform. How about you pull up your data platform during this consultation? Because I'm asking you specific components of it. I think that that gets individuals in the habit of combing through that information, whether they're the ones working with the client to complete it or entering in that data themselves. They're still able to utilize that data across all members of the team to help inform some of the stuff that they're doing with clients.
Right. Okay. Yeah, that's a really great explanation of the implementation. Just basically asking them how do they access that information, and this should hopefully be the obvious answer to, oh, well, it's right here in the measures.
Mm-hmm.
Yeah, thank you very much for that.
Yeah, no worries, Kyle. I think then there can be follow-up, right? So a good example of this is, I think Steph was doing an echo clinic, and some of the notes that I put on after looking at like their data platform was like, there was no PHQ-9 on this specific case presentation. And so you could follow up, right? So how is it going with employment or educational goals with this specific client that you're talking about? And if they go into the data platforms, it's like, well, this isn't entered. Well, what are the difficulties that you're having entering in this information or gathering this information from individuals? And it's going to be one of the two things. I don't have time to do it, or the client refused to do it. I think if it's the client refused to do it, then it's just like, well, let's think about the approaches that we're using to introduce these measures. Are you introducing it in a way that is like based off the data platform, and because we have to do an evaluation, can you please answer the following questions? Less likely that somebody is going to complete that. But if you're asking questions in a very conversational way, like, do you have an employment goal? What do you want to gain out of your participation in coordinated specialty care, right? And the New Journeys program. Let's work towards that. Can you tell me a little bit about those goals? Let's work towards that. Do you feel like you're making progress? What things would you like to work on, especially as it's related to employment? Can I get you connected with any of the resources embedded within the community? Then you're answering those questions that's in the data platform, but you're not looking at it from the perspective of, I'm doing this for an evaluation, which a lot of the times, sometimes if that's how it's approached to a client, you may see a lot of client refusal.
And that's something that I think I include a lot more in trainings, is the bringing paperwork to a session kind of thing. And unless it's absolutely necessary to do so, that more, like you said, conversationally accessing that information and being able to have a trajectory about how it might be utilized. So that was very, very well explained. So thank you so much. I'm just making sure I have my ducks in a row in regard to how I will explain, the value of these measures. So thank you.
Yeah.
At the expense of adding another measure, but I'm just going to say it. Don't hate me. Is there any, I didn't see, but any like family satisfaction measures? Because I remember when I worked in another FEP program, there were ones that the family could fill out. Because I think in terms of like family ed calls, I think measurement-based care can definitely be used to build family motivation, show them a sense of hope.
I'm pretty sure Brian's pulling this up for you, Concha. So we used to have family satisfaction measure, right? And it's the youth services survey. And it used to be mandatory, and then nobody was completing it, right? Because we do have, so Brian was showing you all of the client there is a family as well for family members that are engaged or not engaged, right? So we can kind of capture that. But now it's an optional measure.
Yeah.
Correct me if I'm wrong, Brian. It's an optional measure, and it's also the most infrequently completed measure. And I think you also bring up a good point. Like, it would be great if this was a measure that was consistently used for each team, because the one thing that we actually do not capture for clients and for families is satisfaction with surveys, satisfaction with treatment. We don't capture that at all. And so I don't know. I think that those things can come up like during your consultation calls. Is this a measure that would be beneficial, right? And then we could make sure that it's integrated into everybody's data platforms. But right now, optional measures, we give sites the choice of whether or not they want to include it or not.
Right. Okay. I mean, I see it if you're in the Word doc that you shared. Um, yeah. I can ask them, I can sort of survey them and so it would have to be taken done at the 6 month mark. Uh,
Yeah.
yeah. I recently saw Sri Vidya Iyer from, I was telling Mackenzie this, from McGill, who does a lot of family work in Canada, has in 2022 she published family focused as well as patient focused measure to capture satisfaction with specifically FEP services. So I think this one is also worded a lot in like in terms of child. Uh, so that I don't know if you've seen that one. But I like the measure. I think it's very sort of it's really like simple language, fits a lot of like parameters. Let me pull it up. Yeah, it's called, I'll send you the citation or let me send you this. The measure is embedded in, it's in the appendix or supplementary material. So and they did some cross-cultural validity as well. She does a lot of work in India.
Well, thank you for your time. I see that we're over. We talked about this for a long time, which means it was a good topic to bring to a conversation. So thanks, Dooney and Bry, for joining us today. And I know that Mackenzie wanted to make sure that folks were registering for the startup training. So if you can just fill that out. And then did you want to say something quickly about materials, Mackenzie?
Just a reminder that we'll be printing out everyone's materials, slides you want printed, or any other handouts. So please get those to us as early as you can so we can stuff those folders, and anything else you need material-wise, please let us know.
Never, Akanksha.
Please let me speak. So Ashley brought up yesterday, Ashley Moore, in the family ed call, and she was like, "So is Raida no longer a team? What does that mean?" So I think I don't know if you've already made the announcement, but can we make a general announcement of like the status? And I think there's like, when you don't speak about something, then like mystery gets created around it. Why did they leave? And so, Cami, if you could, no, you're not going to be there.
No, I'm not going to be
Are you
there.
going to be there? Is Maria going to be there?
Yeah, Maria should be there.
So I think Maria should, Mackenzie or Cameron, if you could pass it on, if she could just make a general announcement of like, just like being transparent about that they've left the network, but they're still accepting referrals. Because especially those in King County want to know, right? If the referrals can still be made and what the status of that team is. It sort of was like brought up in this way of like I heard through the grapevine. What does this mean for us? And uh, I think we should be transparent in our announce.
Yeah, I think we did announce it in a echo clinic 2 months
Sylvia
ago.
Margaret there. She was away for cancer
Yeah,
treatment.
exactly. Yeah. And we can address that again, that we've had further discussion with them and that they're still continuing to accept referrals, and we can frame it in that way so that for those who didn't catch the information, they can catch that information, and for those that have already, they have the updated.
And then like everybody else seemed surprised, so I'm like, are you not listening to announcements? It's like, okay. Hi Kyle. And then one quick thing, and others can leave. I just want Cami, you and Mackenzie to know that this has come up before about Spanish language materials, and so
Yeah.
far the only translations are the old version of Navigate. So Victor as well as Andrea have volunteered to help us. So what I was saying was like, if we have the money, we should get like a professional service, and Victor's recommendation was a team-based approach to translations, or different iterations of Spanish are captured, and different idioms, different examples. So I think if we have the money to be able to get a professional interpreter and do a kind of more culturally appropriate translation, would be great, and could also be a service, like that we provide the rest of the navigate sites, or like just share as a resource, kind of like ISA has their materials. uh, and there are frameworks for translation we could be using, but also, do we have the money to pay for their time, right? Andrea and Victor and Nancy and anyone else who wants to be part of the project, but they're really jazzed about it and want to do it. But of course, we shouldn't take advantage of their time.
Yeah, yeah. Okay. That sounds good. We can bring that up in our next core meeting with Maria, just to see what the funding would look like for something like that.
Yeah.
Cool. All right. Well, thanks everybody.